want to talk this morning on some of the strategies for the practicing physician to prosper in the new healthcare system. This is probably, as you might gather, the most popular talk. This is one I get invited most for today. It is, as all of you know, we're sort of in an upheaval in the healthcare system, but I think despite whatever happens, and there's the Republicans are certain it's going to be repealed, the Democrats are certain it's not, but whatever happens, healthcare will never be the same in this country. And what I'm going to talk to you about today really will apply in the future, whether this particular bill survives or whether some other bill comes along. Because we have turned the corner on many of the aspects of the old healthcare system, and they'll never come back. Alan is right. I have read the bill. I've actually read it twice, and it says something about my life, and have really put together some different types of talks. This one deals with a physician. I do one on how it affects women, and do another one on how it affects GME. So today we're going to talk on how it affects the practicing physician. The bill, as all of you know, was passed into law on March the 30th, 2010. So I think people sort of forget that this bill is almost a year old now. Many things have happened already that would be very hard to turn around. And as you watch the politics at play, one of the things that you notice is that in terms of the repeal of the bill, and of course they're going after the access part of it, two judges have ruled that it is not constitutional. It is not constitutional. Two have ruled that it is. But if you look at what the federal government has done with the two cases that in Virginia and Florida, where they've said it's unconstitutional, they didn't appeal the one in Virginia till the very last moment that they could, and now the other one still has not been appealed. Now, what does that tell you? It tells you that they want to get as much of this bill into play, into practice, so it's going to be very hard for the Supreme Court 2 or 3 years after the bill is established to throw it all out. So that is the tactic that the Obama administration is taking. This lists the principles that we're going to talk about today of this new bill. And the talk is really divided into 3 parts. We're going to talk about what's in the bill for 10 or 15 minutes. We're going to talk about how that affects the practicing physician, and then we're going to wrap it up at the end. Now, in expansion of coverage, what is the problem? Well, the problem is that there's a lot of people who don't have insurance. It's estimated anywhere from 40 to 50 million. But if you look at Texas and New Mexico, about a third of our population does not have insurance. Now, this slide is for women, but men are the same. So we have a huge problem in Texas. What this bill does is that it actually requires or mandates that about 94% of Americans will have insurance by the year 2019. What isn't really well understood is how they will be brought in. I think most people believe that most of those will be brought in under Medicaid, but only about a third of them are. The other 2/3 will have, in essence, private insurance brought in through the American Health Benefit Exchanges, which are in the state. There is a penalty that you all have heard about up here. Not a severe penalty, but at least a penalty if you do not take part in this. And guess who monitors that? Anybody want to know which department of the government monitors whether you have health insurance or not? The IRS. And they are having to hire some incredible number of new IRS agents just to monitor that. So this isn't, they're not taking that lightly. There will be penalties, although they're not severe penalties. So in the expansion of access, the first way they're going to expand is through Medicaid eligibility. Now, they will cover up to 133% of the poverty level. So anyone who makes $14,000 as an individual or $30,000 for a family of 4 will be eligible for Medicaid coverage. And this is a fairly significant increase from the way it used to be. Certainly in our area of women, we have always been very aware that Medicaid does a lot of coverage, but men, they have not covered in the past. So there will be a significant increase. The other area, which is the one that is sort of sneaking in, but people aren't quite totally aware of what all this means, is that there will be new insurance companies established. These have a fancy name called state health insurance exchanges, but they're in essence insurance companies. That each state is obligated to set up 2 new insurance companies, and they have the option of doing this, or if they decide not to do it, the federal government will come in and do it. And the federal government is supplying significant amounts of money in the formative stages of these insurance companies. And this is what they cover. This is what they're obligated to cover. It's a very, very excellent insurance policy. It covers maternity care, covers prescription drugs, all emergency services, and preventive services without any co-pays. So anything that is considered to be a screening procedure, colonoscopy, et cetera, will be covered independent of any co-pays. So it's a very broad plan. Now the grandfathered plans, those that were in existence on March the 23rd, 2010, do not have to play by the same rules at this time, although most people think that will change. But basically, this is the coverage. They cannot deny for pre-existing conditions, certainly pregnancy, and something that I think most people aren't totally aware of is that only about 13% of plans in this country currently cover maternity coverage. If you're pregnant when you join the plan, then they will not cover you. They consider that a pre-existing condition. None of them basically have covered anything related to domestic violence, certainly any domestic violence, training, and so on. They cannot deny for medical history, previous problems, genetic problems, their health status, or if they're disabled. And there's no waiting period greater than 90 days before the coverage takes effect. So it is actually an extremely ideal policy if you're a consumer. It covers things quickly, it covers them both preventive and full care, and you get it very quickly. So here's what has taken place already. Insurers cannot deny people. They must take everyone who applies for coverage during a defined enrollment period. So you cannot turn anyone down. They can only base their premiums on age, tobacco use, and geographic area, and whether the coverage is for an individual or a family. So there really isn't any way that they can adjust the premiums for previous health conditions and so on. They cannot deny coverage because of a person's health status. What important one here is the genetic information, because that is one that many people worry about as we move more and more into an era with BRCA and other mutations. People are reluctant to have them done because they don't want the insurance companies to know they might be denied, and this plan they cannot. They estimate all lifetime limits and restrictions of annual limits. It used to be that many policies, probably up to 2/3 of policies in the country, have a limit anywhere from $3 to $5 million. And when you reach that, the insurance company can cut you off. And it's virtually impossible to get other insurance. They also restrict any annual limits. They cannot remove anybody from the plan because they got sick. And that goes on pretty commonly now. If someone gets a major illness, it's like having 2 car accidents, your insurance company can drop you. Well, it was very common in the healthcare industry that you could drop people because of illnesses that they got. And it does allow parents to keep unmarried children up to age 26. It does prohibit the use of pre-existing conditions. It requires first dollar coverage for all common screening procedures, and all maternity and newborn coverage will be in place by 2014. So already in place for almost a year are all of these measures that, that we've listed here. In 2014 is when we'll get the total expansion with the state health exchanges and with the Medicaid eligibility. The current status of the health exchanges is that 29 states have set up health exchanges. The others have not. Some of them are refusing to do it because they do believe that with the current political climate in Virginia and Florida that it will be overturned. But in fact, if they're not set up, and the government hasn't set a date yet, but certainly it has to be before 2014, they will come in and set them up for the state. You cannot base charges and premiums on health status or gender. I think most of the people in this room know that women pay higher rates than men, and certainly women who own companies pay higher rates for their employees if their employees are mostly women. So there has been a huge gender gap. Why is that? Well, women go to the doctor and men don't. And women get pregnant and men don't. And so they're considered a high-risk individual for that reason. There is a catastrophic health plan that is now in place, or that will be in place then, and the individual requirements to have health insurance. One of the major changes that is taking place is how people are going to be paid and how they're going to practice. The government has made it very clear that they do not want to write checks for individual physicians. They want to write checks to companies, and those companies can then pay the individual physicians. And that has led to this accountable care organization medical home concept. Now, this isn't very different than what took place in the 90s when the HMOs come in. It's almost the same. And the people writing the law and the people certainly writing the regulations, 70% of them are the same people that wrote the Clinton bill in the early 90s. But now they're 20 years older and supposedly 20 years wiser. And they certainly learned a lot from their debacle with the Clinton plan, where it just went up in flames. So you remember in those days, how were we going to be paid? All the money was going to go through the primary care physician, who would then pay the specialist to whom they referred the patient. Well, that didn't happen. This is the same concept. Somebody's going to get paid, and everybody's not going to get paid individually. Now, the accountable care organization, you can't go to a meeting today that they're not talking about accountable care organizations. And everybody has a different concept of what it means. Basically, it is really nothing more than a group of people working together, a group of doctors working together to supply care for Medicare beneficiaries. And it's believed that it will expand beyond Medicare, but right now it is for Medicare. And it is an attempt to align both the primary care with the specialty care, exactly the same as the Clintons tried to do back in the 90s, where the payer, a check will go to a payer who then will pay all the people that took part in the care of that patient. Now, obviously, the government believes that the money saved from this is just going to be enormous. And so you get to share the savings. If you show the savings, you get to share the savings. But it's going to take a well-designed organization to be able to do that.